just casually, and introduce your name and say that I have read the labor ward board. I have gone through it. I have seen, I have noticed that there are some urgent cases. Apart from that, I'll go room wise, and then I will be prioritizing my, you know, cases or the patients according to urgent, semi-urgent, and routine, and I will delegate the task to my team according to their competencies, because I think patient safety is the utmost priority. Because patient safety is our utmost priority. Keeping it in mind, I will be allotting the cases. Just that, if, even if you don't say this, nothing will happen. Just, if you see the board is quite big and you are going to waste your time in speaking some fancy lines, leave it, okay? And just go on. And in the whole labor ward board, you have to ask the required findings. Don't keep on speaking and speaking. Keep on stopping and ask only relevant findings. When this time I was taking mock exams, everyone was speaking and asking. Speaking one line, asking in another sentence, then speaking, then asking. You have to uh, first read the station carefully, then you need to know what is the most important points, because somebody is taking your exam and continuously, okay, tell me pulse, okay, tell me blood pressure, okay, so what is the PV? So first you should know that what you need to ask. Okay, don't take viva of the examiner. Just think about the particular case that has come to your labor ward, and how you want to manage it. What other information, suppose if your junior colleague is giving you the overs from the labor ward, what do you want to know? Would you like to stretch upon the overs to 1 hour, or you want to just know the crisp findings? Okay, like but you cannot miss the major things. Like if a patient is bleeding, you quickly have to ask the assessor that this room, I find that it really need our attention urgently. So would you please tell me what are the vitals, and is she still bleeding continuously? And whatever, like APH or PPH thing is there, you have to ask the 3 4 set questions, which if you will not ask, they will not give you marks. So all the questions which are required for a particular station, okay, that you have to ask. Like if patient has come for VBAC, she's in labor. Suppose if patient is having previous cesarean and she has come in labor, and so you will ask the examiner one important question, that has the consent been reviewed with her for VBAC? Is she, means, maybe the plan has been made already, but you have to always review the consent for everything whatever you are doing. So you have to ask, has she been agreed to the, because if there is not it's not written there that this patient in room, she has come with labor pains, she is in labor, previous cesarean. So first question you will ask, when you will start asking questions, and ask question in one go. So just ask the examiner 2 3 questions at a stretch, in between or in the beginning, however you are feeling okay with it, but don't keep on annoying the another person. And be ready, be prepared. You make your own set of questions, complete set of questions for each scenario, whatever you can imagine, okay? And keep on using the buzzwords in between. Like if you are talking about umbilical cord prolapse is there, you will ask, in the set of question, one question you will ask is that, what is the CTG findings? Is it um, is it a good CTG? And if they'll say no, it's pathological, okay, then we have to take this patient for category 1 cesarean section. Okay, so you, emergency cesarean, we'll take her for emergency cesarean. That is another way, but the good way will be to categorize it in 1 2 3. And then if there is a PPH patient, you'll ask about the PPH kit, and the team, the code, and if there is any patient for LSCS, breach in labor has come. So you will take the name of, will I'll see, she's not willing for cesarean, vaginal birth, or she's a primey, so cesarean is the preferred method for her. So I'll take her consent and prepare her for category 2 cesarean section, and we'll make sure that WHO safety checklist is also there, and consultant will be informed. Then MDT, involvement wherever it is required. Okay. And then because in suppose it's thalassemia patient has come, so you need to know what set of questions you are going to ask, and what buzzwords and important highlights you will be saying to the thalassemia patient. When was the last HB? When was she be given chelation therapy last? What is the cardiac status? What is the, these all things, if it has not been given. Okay. So if sickle cell anemia has come, then you will be saying about, talking about dehydration, that she will be given IV fluids, and last HB you will be asking, and like this, specific in all. Like if I'll be talking about all the stations, that will take too long. So you make your own stations according to the buzzwords and according to the questions you are going to ask. And if the answer is already given, you will be seeing those answers. Like if the patient has been delivered and she had a tear, just ask, you should be ready with your questions. Is patient vitally stable? Is she bleeding heavily or actively bleeding? Is there, has any senior assessed the tear extent? What is it, a third degree or a fourth degree? Okay. Or an episiotomy, if it has been given in the station that patient is for stitching of episiotomy, then you have to ask, has anybody senior assessed the episiotomy? Because that can be an extended tear. So somebody should examine that, and that shows that you are an alert person, you're not missing on anything. And then you can add on few things, if episiotomy suture is there, okay, what is the blood group of the woman, and how's the baby doing, and is the patient actively bleeding or not? Okay, then apologize for the delay, but send somebody who can, or allot the task to the team member, that I'll allot this task to my midwife who knows the suturing, who has been, or my ST1, if they are signed off for episiotomy suturing, or any of your colleague who is signed off, or the midwife who is signed off for episiotomy suturing, you will allot that task to that person. If you are confused really what are the tasks to be given to ST3 or ST2 and ST1, it become confusing. Now also I get confused for what duty is for what, for whom. So you can easily say whoever is competent and signed off in OSITs, they can be doing the, I will allot that task to the person, because maybe some tasks ST3 can do, but till now she's not signed off. Then you can't give the task to her, okay? And put your, according to NICE guideline, it is a suspicious delay of labor. So we will be repeating the PV after 2 hours. Like this, you have to give the reference of guideline, give evidence based practice. If it is more than 1.5 liter pph, then you say I will do the incident reporting. And if see somebody, if third degree perineal tear uh, has happened, then you have to do the duty of candor. Okay, I'll be explaining this to the woman that this has happened. So involve the consultant whenever it is required. Okay, there are a set of conditions in which you have to involve the consultant. And whenever you are in confusion, okay, whenever you are in confusion, just go by the go by the situation, where what will you do? Will you, like, if you ask me, I will not at all open a case of abruptio placenta on my own. If I'm a registrar, I would definitely inform my senior resident or senior registrar, or consultant will be informed by the senior registrar. We can't do that, okay? If a thalassemia patient is there in labor, you will be involving your consultant, MDT has to be involved. And breach in labor has come, you will inform your consultant. If preterm patient has come, okay, and there is no bed in the NICU, you will be informing your consultant for IUT or EUT, okay, extrauterine or intrauterine transfer. So there's quite a long list in which you have to involve your consultant as well. So those things are to be, kept in mind. And this is a very simple station if you are going stepwise and systematically. And don't get confused, just put yourself in the labor ward situation and keep on speaking and asking. But before that, like, you guys have 1 month now, so keep on making 4 4 5 5 situations every week, you can say. So there are only, like, in GDM patient, if there is a GDM patient, you will ask about the recent, what are the blood sugar levels, is there, what is the expected birth weight of the baby, is there any history of, um, past history of shoulder dystocia. Okay, then we have to be careful that this can be a shoulder dystocia this time, and we need to be alert. And this, you have to speak it out from your mouth, so that the examiner, if that's a labor ward coordinator, you can talk like this. To the consultant, you need to be more formal. Okay. And you need to be communicative with the consultant also, because you are all are, working in the same hospital. And you all have to be communicating, and not communicating nicely, whatever is required. And SPAR pattern you can use if you are very confident about, or if you have that much of time. Otherwise, just put every station in the situation background and assessment and recommendations. But here nowadays, labor ward scenario has changed, like, though it has not changed, it was always like that. We were reading in it a wrong way. So if it is possible, it's okay. Otherwise, don't go for it. Try to put your statement systematically, starting from the history points, whatever you want to know, then pulse, blood pressure, vitals if you want to know, or in examination you want to know anything, or if you want to know about the PV and pelvic examination findings. Okay. So you have to go, like, very systematically from up to down, as we do in all the stations, so that um, just a second. Wait a minute, please. Okay. So just put it very systematically. Okay. And now coming on to the labor ward one. Um, Anybody, if you want to do the station, you can do. Does any of you want to do this? Okay. So you can read this scenario. Okay.
This
So
conference will now be recorded.
this is like you're a fourth year specialist registrar. You are ST4. Suppose it will be ST5. Mostly it will be ST5, working in a district general hospital. So you know the situation. Like, you are in district hospital, you start your day on call at 8 a.m. Like, it's the morning shift. You have one ST5, ST1, and ST3 with you. You are also supported by six midwives. Two midwives can suture. And if you don't remember that, two midwives who can suture, one cannot suture, I have allotted one here, one there. Don't worry about that. You will not be having this much of time. Just say, i'll I'll give it to the trained midwife who can stitch. And okay, can suture, second degree perineal tear and episiotomy. Third degree cannot be sutured even by ST1. So and some can cannulate the patient. The consultant on call is in the antenatal clinic, so that means that you can contact the consultant. And just let me tell you that even if there are suppose there are three emergencies. Okay. So you can take help from the another consultant also who is not on call, because there can be some second on call, right? As we have in our hospitals, like, we have one first on call whom we can call, take help from. And if suppose another emergency has come, and we are not able to manage that, so you take help from the another consultant. Don't hesitate to speak this. That will show your situational awareness, and that will show that how safe as a doctor you are. Okay. So uh, Now this is the board. So I want you all to read this board and we can discuss it room by room. And please feel free to speak up and use your brain. Start using your brain very actively because you have your exam in 1 month if you have already booked the exam. So I will be giving some.
This conference will now be recorded.
Okay, so let's start. So, can anyone tell me that what are the urgent cases here? One urgent case. Speak up. Okay, so I'll tell you that these are the, you have to first go to the remarks. Okay, don't see anything in 2 minutes. Go directly to the remarks. Okay, findings. Here in the first box, trial of scar, like it's a VBAC. Meconium, deceleration, urgent. Okay, atosiban infusion, semi urgent, you can say, or routine, you can say, if she's having no contractions. So just leave that. Write in your paper, room number one. Then, geo witness. Okay, now it is only geo witness here. So you go to the left and read what more is important. So grab the 7 para 5. Okay, she is grand multi. Okay, and geo witness again. That's important. Semi urgent. And then because dilatation is 5 centimeter, you can see. So she is not fully. So just grand multi, geo witness, semi urgent, and it's important case. Then placenta previa bleeding. Now this is your most urgent case. Okay, you have to speak it first. So bleeding is always first. Okay, bleeding is mother. Baby is secondary when baby is inside the uterus. Mother is primary. So though both like here decelerations are there, here CTG is showing reduced variability. Both are having fetal problem, but major placenta previa bleeding. Here mother is at risk. So our first priority is mother till the time she is pregnant. Then third degree perineal tear, semi-urgent. You have to operate it in the OT, operate, I mean, stitch it in the OT under good lighting. And then there is A&E. A&E handover has been given like we are always being given some patients from the emergency also, that there is one emergency which has come just now when the shift has been changed and you people have to go and see the patients. Okay, so these are those patients, and somewhere in the exam you may expect the empty rooms that patient is coming. Okay, patient is being transferred from the midwifery unit, then you and the room is empty. So when you will be speaking about the labor room board, you will be talking about it. You can't ignore that thing, okay, that the room is empty, so you ignore and go on. So you just have to say 1 or 2 lines. Okay, we need to assess the patient. Do you have any idea why she is being referred? hmm we need to assess for the emergency because there must be something that they are referring her to us. Just one line that you're aware that there can be, like in our labor room we always ask, no, if she's coming to us from that far, that means there's something, like otherwise why won't they deliver her? If she's coming from any hospital, if she's coming from home, then okay, is it a normal case, laboring case, or do you have any idea? All right, we need to assess her the moment she comes. You just inform me, okay? Yeah. So just like that, to your labor ward coordinator, you can say, to your consultant, you can say, you can say that okay. So when the patient will come, I will first, if I'm busy, then I'll send my ST1 or ST3 to see the patient, to assess the patient quickly. And like this you have to deal with any of the case, any of the patient. If there is empty room, you speak accordingly. If there is A&E patients, you will speak accordingly, that which team member you'll be sending and what this case can be. That's all. Okay. So here, if I will be giving you example of 6 and 7, so here you can see that she's 7 weeks and cervix open and bleeding present, and patient is in A&E, she's 22 years. So you can think about the incomplete abortion. Okay. So okay, she the cervix is open and she's bleeding. um 7 weeks amenorrhea is there. I would like to know about the urine pregnancy test if they have done it. And apart from that, it can be an incomplete miscarriage as well. So let us shift her to labor room, and we can have ultrasound bedside because it's bleeding. We need to assess her for bleeding and her vital stability as well. She may need bloods also. So I would suggest that we put a white bow cannula to her first and start the fluid resuscitation, and bring the patient up after and bring the patient to the labor room. Okay. And then so that we can start with the procedure if she requires suction evacuation. So like that you dealt with that, and I will send my ST1 for assessment, right? And then you go to the so this is an urgent case. We need to act upon it quickly because bleeding is always urgent. Active bleeding, right? And then para 1 6 weeks amenorrhea. This is the seventh case. Okay. Pain in left inguinal fossa and spotting. So you just say okay, so we need positive pregnancy test in A&E. So you just say that we need to um, we need to say because she is having spotting and pain, we need to exclude the possibility of ectopic pregnancy. So I would like to get her ultrasound done urgently, and to rule out the ectopic, and also the serum beta HCG need to be sent. She need further assessment. I would ask my ST1 to assess her as well, and if need be, I'll send the ST3. um, and a quick urgent scan is required for her as well. Okay. So you dealt with it because she is not in labor room, but you have to get them to labor room. And in ectopic pregnancy, she is having pain and she is having left inguinal fossa. So you just left inguinal fossa pain and spotting, so your suspicion is ectopic. So you send a serum beta HCG, get one ultrasound scan done, assess her vitals. How is she? Is she stable? Is there any tenderness in the LIF, or the abdominal tenderness or rigidity is there? Is there any signs of, you know, internal bleeding or internal hemorrhage? Is it ruptured? So all the possibilities can be there. So we need to assess her quickly. So I'll ask my ST1, and I'll also send midwife along so that they can simultaneously assess both of the patients. And I'll ask I myself can go if there is any requirement. Then coming on, I mean, this is I'm going to deal in the last, not at first. Okay. At first, I'll be seeing my patients first here who are in labor room. So you just say that I can see that, there is a major placenta previa. So this patient, I will go first to the room number 4. And now what? She is bleeding. So what questions? We vaginal examination not done. Of course, she is para 235 weeks. Okay, and she is 29 years. Major placenta previa. Now she is bleeding. CTG is also showing reduced variability. So what set of questions will be there? So, room number 4, I'll go. It is an urgent case. I myself will go. I'll assess her vitals, pulse, blood pressure, respiration, and I'll check the bleeding. Is she actively bleeding or the bleeding has stopped? So, I'll check the pads, and I also need to look for the pallor, like how much she has already lost, and the abdomen, whether it's tense, tender. Is there any like possibility of abruption also? So we need to check that, and then take a pause. Okay, and if the examiner doesn't say that, then you can ask, so may I know, is she bleeding continuously, and is she having lot more pallor, or what's the latest hemoglobin if we have sent any, and what about the uterine tenderness or any signs of abruption, is it present? Because this is what you need to know to take the decision. Nothing else you need to know. Vital stability. Is she vitally stable? Is she bleeding actively? Is there any signs of abruption as well, like uterine tenderness? Then take a pause. Examiner will tell you, yeah, she is bleeding. Oh, then we need to start with the APH care bundle. This is the buzzword here in APH case. Okay? So just say, okay, we need to start with the APH care bundle. Speak one or two points from the care bundle, and then start with the, okay, we will put two 14 gauge cannula and send the full blood counts because she's bleeding. Anybody who is bleeding, like the patient who is in A&E, tell that we will. I would like that they put the white bore cannula and send the full blood counts and blood for group and save, even cross match we may need. Then send full blood count, cross match, and we need 4 unit blood in hand in labor room because she's bleeding. And we need to take consent for cesarean section category 1. Okay? Cesarean section category 1. Cesarean hysterectomy can also be performed in her. And continuous CTG monitoring as she is already having reduced variability. And I will inform my consultant because consultant need to be there, and will arrange one ultrasound also so that we can see the plane of um, incision. We can check the upper border of the placental localization, upper border localization. So I'll keep a bedside an ultrasound in the OT also, and WHO safety check. That's all. This is how your APH station. I mean, keep it brisk. Crisp and brief. Okay. So she will require this, and consultant should be present there. I will also inform the blood bank that she will require more blood and blood products also, and that will be given according to the hospital protocols. Okay. So that's how you're going to. So this is the urgent case. Let's prepare that. I'll I'll ask my ST3 to take the consent, and or you yourself will go to take the consent because you can be there in the OT. So I'll be taking the consent, and I'll be checking the. I'll be asking my midwife to prepare her quickly and arranging for the OT as well. So I am thinking and speaking here because I want you to think and speak there. Okay, because you can very well, you will be having enough time if you are well prepared. You will be having enough time now because nobody is answering me. I myself is asking question and giving answers. If you would have been attempted at any of you, then I will be asking you questions and you would have been answering me, and I would be saying that how what is the quality of your question and what answers I have to give. And I'm sure that all of you will ask the correct questions because you all are managing the labor ward. So don't worry about that. And this is how you will manage the placenta previa with bleeding. Then quickly come to the first room. Now, my next priority is room number 1 because I can see that she is previous cesarean. Now, peconium has come at 5 centimeter. She was 5 centimeter at 7 a.m. And I can see, according to NICE guideline, this seems to be a suspicious delay for me because in 4 hours the dilatation is 2 centimeter. Dilatation has increased only by 1 centimeter. So that's a, or simply, don't get into this. If you have 10, 12 rooms, just you will be having a lot of short of time. So just say that it's a suspicious delay according to NICE guideline. So now at 9 a.m. we need to see that how much she has progressed to confirm the delay, and she's already past she's already baby has already passed meconium, and there are deceleration. I need to review the CTG as well, and she has a scar. We need to check the scar tenderness. So, and vitals also for the patient. So can you please tell me, what is there any scar tenderness, and what is the status of uterine contraction? Are there enough contractions? And what about the CTG, like what kind of decelerations they are, early, variable, or late, then examiner will be telling you. Okay, so here you have to ask these three questions and you have to go on. Okay, and you need to say that I'll inform the patient also that the situation is this, and we may need to take her for cesarean section if it's a confirmed delay, and there is CTG abnormality, pathological CTG. So we have to decide between the cesarean section here and fetal blood sampling, right? Depending upon the CTG findings. Okay? Because if delay become confirmed, then you have to offer her syntocinon because SROM already has happened. Syntocinon in case if the decelerations or if the CTG findings are suspicious, then you will offer her fetal blood sampling. And if the CTG findings are normal now, if they say they were persistent variable decelerations, but now it's fine, then you say okay. And if it is a confirmed delay, we will put her on syntocinon, and you know, and but now as she's having deceleration, you can't start with conservative. You can't start with synto and anything. So you say that because now CTG is suspicious, if they say it is suspicious, then you say okay, we will start with the conservative management and we'll repeat the provisional examination, but she may need cesarean section. And if CTG get abnormal again or suspicious, then we need to perform the fetal blood sampling, and that's it. Okay, so just think and speak, think from your senses, like what will you be doing in your labor ward. And even if you do not complete this station, that's okay. If you're talking sense, if you're talking relevant things, I was able to complete it, but when I completed, the examiner said, there in room number 3 the patient has a cord prolapse. So because I then that emergency I could not deal, but just I said, okay, but I need to know that. Then I just said one word, okay, oh, that's an emergency. Now I need to know about the CTG finding and the pervaginal dilatation, pervaginal findings. What are those? Okay, so just that, and it rang. Like I had to go to the next station. So even if you're not able to complete your this thing labor ward, then also you will be considered for, like, you will not be failed because of 2 3 stations which you have left. But if you have performed very good in 4 5 6, like more than half stations, if you have covered and you have covered the urgent cases, surely you will pass with good marks. Okay, so just scan for the urgency, just speak what is making sense, don't annoy the person, just talk very much, uh, just talk the things which are required. Unnecessary ratty ratty, that those things which are, everyone is speaking, that is of no use. Okay, now after these two cases, you will say okay, so one, I need to inform the consultant will be in this case, so I will be assessing this case again. I will ask my ST3 to assess this patient, and we need to operate, we need to take a decision for her, so I'll assign this task to my ST3. Okay, and then this atosiban, then now I will go room wise. So room number 2, this is atosiban infusion, primey, 19 years, 2 centimeter. So I'll see how she is responding to the infusion. Is she now contracting or is she fine? And I can see she's 19 years old, so we need to check her last hemoglobin. Have we done for her? And is there any other background hidden agenda? Like, have we checked for that? Any domestic violence? She's having preterm labor also. Any other thing? Because it's a teenage pregnancy, so malnutrition also. We need to assess her for her BMI. Just say one or two things because that will show that, and maybe there is some mark why they will give 19 years here if you will not address it. Okay? It's not random. Nothing is random in RCOG. Everything has a meaning. So if they have given 19 years, there can be teenage pregnancy thing will come here. So you will ask the buzzwords of the teenage pregnancy, questions from the teenage pregnancy. How is her BMI? What's the latest hemoglobin? Because there can be there can be malnutrition and preterm labor. Yeah, it can be a complication in teenage pregnancy. So is there any, we need to check about any hidden agenda also, like a support, mental well-being. Just say this like that, so that examiner knows that you are aware that it's a teenage pregnancy and we need to say. So is there anything in particular that we need to pay attention also, like for about the teenage pregnancy? Then he will tell you. He may tell you, because the pattern has changed now, and there are very new things coming up, so you just can't miss any finding. Okay. And she's 29 weeks, so the most important thing you will ask after, whatever you're thinking, first here in the first box you can see name and age, so age you will address. Then she's a primary, she's 29 weeks only, so you will need to check that, has the neonatologist been informed, counseling has been done for the couple, and is there any bed for in is there any bed available for for the baby in Scubu? Because then they will say yes or no. If they'll say no, okay, if there is no uterus is relaxed, we may plan the intrauterine transfer for her. Then take a pause. Let him think that yeah, that has been done already. Okay, then it's fine. I'll make sure that she being transferred carefully and according to the protocols. Say it and go on. Then this one. Okay, she's grand multi. She's post dated also. Oh, and you know, be natural. Say whatever you're feeling. So, like 41 weeks, she's grand multi. She's post dated, and here, okay, she's 3 centimeter at 1 and 4 centimeter at 5, and then again only 1 centimeter in 2 hours. So it's a confirmed delay, right? Prev- So you will say, oh, so she is a grand multi. She has a confirmed delayed labor going on, first stage of labor. Stage also you have to speak. So, okay, it's a delayed first stage of labor, and she's a Jehovah Witness. So, we need to address many things here. As she's grand multi, she's at high risk of PPH. So, we need to check whether, like, um, what are the strength of beliefs, like will she be receiving blood in case of emergency, like if she'll bleed heavily, or any blood products. So I need to check the consent form, like if that has already been mentioned and has been told, or asked from the patient. Take a just slight pause of 1 second and look at the examiner for the answer. Seek answer from examiner, and they will be telling you if they want to tell you something. I need to check that can she receive blood in case of emergency. Okay, because then we need to send the cross match and keep it ready if she can receive. Otherwise, we need to tell her we are in district hospital now and need to check the availability of interventional radiologist also for umbilical or uterine artery embolization. And now she's contracting, we can't transfer her. Okay, so you need to say, as this is the confirmed delay of labor, we need to know whether she's contracting, what's her last hemoglobin, is she contracting I need to check the uterine contraction for strength, duration, and frequency. These three things you have to ask in every patient, whomever you want to know the uterine contraction. Just ask what is the strength of the contraction, frequency, and duration of the contraction. I need to know that. And then, is the pelvis adequate? Is there any I need to assess her for the abdominal pelvic examination to check for any element of CPD. And what are the past birth weights of the babies, and is there any difficult delivery in the past as well, and is there any history of PPH in the last deliveries, right? So that you have asked the relevant things now. Okay. And I'll make sure that there are vibro cannulas in we have already put in her. PPH kit will be ready, and once she will and we may need to do the ARM. uh, so may I know what is the status of membranes? So that you will be asking the examiner. Okay. And after they will say that ARM has already been done. Okay, then we may need to seek the possibility of injection oxytocin according to our hospital protocol. Will be putting it, but we need to be very careful as she's a grand multipara. There can be, like, there should not be uterine hyperstimulation. And apart from that, need to talk to the anesthetist because she will be requiring epidural analgesia. Okay, so if you're talking about oxytocin, talk about hyperstimulation in grand multi, talk about epidural. If you'll miss epidural, you will be missing the buzzword for sure, like the bullet word. Okay, bullet point. So oxytocin will come along with epidural because it is in the guideline. You can't miss that. That's a patient safety. That's for patient. Like, you, that is to be offered to the patient. If patient want to receive it or not, that's her this thing. After informed consent, she will be given all the things. Okay, so that thing you can speak in the beginning also, that I'll be going room wise, I'll be keeping patient safety as my priority, and informed consent will be taken for all the procedures from the patient. That you say this, and if you, because then your consent part will be marked tick. Okay, so you will be given marks for that point, right? So you speak those common points in the beginning if you want to, so that those points are not being missed, right? Like, I will be checking for the analgesia also, that women are, they are they're comfortable in the labor room. Okay, if they are laboring women, I'll check for the analgesia so that they are comfortable. And then room number 4 we have already done. She is having third degree DS, so same questions. Has somebody senior assessed in good light, and is she actively bleeding? She delivered at 7:15. All right, so we need to, I need to check what is the blood group of the woman. Is she vitally stable? Okay, so then make her comfortable and apologize because we need to take her for the OT. So let's settle the first emergencies, and then we can, stitch her in the, take her in the OT. So I need to check, is the OT available at this point? Another OT, because we may require two OTs for the two emergencies. Is any other OT available? If they say no, there is no OT available for the next 3-4 hours, so you say okay, then we can do it in the labor room itself. We need to take the consent from the patient. Yeah, okay. In good lightning conditions, we can perform it. Then A&E patients I've already discussed, right? So this is the simple stations which I have taken. Okay, uh, you can say these are the traditional ones. Similar stations, very simple format will come in your exam also. Okay, one or two urgent conditions or difficult things will be put deliberately, maybe one or two, or you will be told that in this patient, or suppose like in this patient, there is a room, like if it is not placenta previa, there is a maternal collapse. Okay, so you can see the collapse thing, and you will say and say, you will start speaking, okay, this is a maternal collapse, we need to see ABC and this and that. Just ask her, okay, so when did this happen? Has she been taken care of? Or is the code blue has been activated now, or it has happened before? Or how is the patient doing now? Then they'll say it has happened just now, we have just heard the buzzer. Okay, then let's quickly go to that room. Maybe. And similarly, if there is a pph like 1.5 liter blood loss has happened, then you will not start your own rhythm. Ask first, okay, so can you tell me that whether has she been stabilized or she's still bleeding? Maybe she's already been taken care of, and we start from the beginning, and we lose all the time, and in the end we examiner says that everything has already been taken care of. What will you do then? You have already killed your precious time. And moreover, examiner is also not happy that you are not asking, just saying your own ideas. So whenever we go to labor room, and then they say that there's a pph patient, first question you'll ask, you'll not run towards that patient, you'll just ask, oh, is she still bleeding? No, no, everything has been managed. Now we are giving her bloods, and anesthetist is there with the patient. Oh, okay, then it's good. But we need to keep an eye, and we need to do the incident reporting because she's already lost 1.5 liters. So we'll debrief the patient also, because that must have put some, we need to talk to the patient later on, and we'll explain it to her. Okay, and how's the baby doing? What's the blood group of the woman? And if it is negative, just say we'll give NTD. Okay, and if they say I don't know the blood group, then say okay, if it's Rh negative, we need to give NTD. So we'll check it. Just say that and go on. If you find that you have asked some weird question that was not required and examiner is making face, don't get disheartened, just be confident, you are a clinician. Okay, so whatever you ask, it's your feeling. All subjective feelings cannot be, maybe you are thinking right, it's not in their template, so maybe they have missed it. Okay, so be confident, ask whatever you're thinking, but your thinking should be very, very correct. Okay, you should be speaking buzzwords, you should be telling them the guideline. If it is a confirmed delay, you will be doing the procedure, like you will be doing something for the patients, you can't leave her. And if it is a suspicious delay, you can assess in next 2 hours, and tell the time when you will assess her and who will assess her, and what will you do if you find it a confirmed delay, or if it's like if it will be okay, you will just observe. Okay, and like in previous car patient, you will say the continuous CTG will be there. Here also CTG showing reduced variability, just say continuous CTG will be there. So just simple things, and keep it simple, keep it the way you will manage any emergency which has been written here, like in non major placenta previa bleeding, it is written it's bleeding. So you ask her that I need to rush to that room because she's bleeding, so but I need to know whether what are her vitals, and is she still bleeding, and how much is the amount of bleeding, and how much she has already bled. Is there any possibility of uterine abruption also? What about the uterine tenderness? Okay, CTJ is also not good, so we need to terminate the pregnancy now. So category 1 cesarean will be offered to her, right? And major placenta previa, so consultant need to be there. And bedside USG for to see the margin of the upper margin of the placenta. Consultant may require it. So basic things, as soon as I reach the labor room, and if I find something, like for suction evacuation, we do it under ultrasound guidance. So whenever I see take round of any patient who is for suction evacuation, and it was previous 3 cesarean, or consultant has to do it, I always make sure that ultrasound machine is in the OT and it's functioning. So you also have to show your this thing, because it is in the guideline that you can see it in the OT before giving the incision. Check the upper margin, upper border of the placenta. That can be done. It is mentioned in the GTG, so you can speak. So that will show your knowledge. You just have to show the knowledge. You don't have to do all the thorough dissections over there. Okay, read the remarks first, find out the things, and if you are having confusion, then go to the left side of the bar or the stations. And empty rooms, never ignore, never jump, and never get stuck also. Okay, so never get stuck also. Just say one line, at least say one line for everything. Okay, like if she's coming from the midwifery unit, and if they say that that's obstructed labor, oh, whenever she comes we need to assess her, right? So like this you are going to do the labor ward stations, all the station, and tell that you are going to give this task to ST3 or ST1. You can give two tasks to one also: semi urgent, urgent, midwife, send ST1.